toxicity. So angiotensin 2 raises the BP by several mechanisms, like triggering aldosterone release, increasing response to catecholamines, acting as a direct vasoconstrictor. It is created in a two-step process. In the first step, renin is released by the kidneys. ACE inhibitors raises BP by several mechanisms, triggers aldosterone release, increases response to catecholamines, acts as a direct vasoconstrictor. Angiotensin 2 is created in a two-step process. In the first step, renin, which is released by kidneys, cleaves angiotensinogen, forming angiotensin 1. Then angiotensin converting enzyme ACE converts angiotensin 1 to angiotensin 2. Forming angiotensin 2, inhibition of this conversion at the either step results in decrease. Inhibition of this conversion, angiotensin 1 to angiotensin 2 conversion, is done by ACE, which is inhibited by ACE inhibitors. It results in decreased BP. So angiotensin 2 is a vasoconstrictor. ACE inhibitors are thought to slow the progression of diabetic glomerulopathy, and diabetes and MI love ACE inhibitors. ACE inhibitors and ARBs cause vasodilation, especially renal vasodilation. ACE inhibitors are thought to slow the progression of diabetic nephropathy, glomerulopathy, and they improve mortality after and LV function when administered after MI. Member of this class of drugs are prils like benazepril, captopril, enalapril, fosinapril, moaxipril, perindopril, tradolapril. Decreased production of angiotensin 2 causes vasodilation. They do not cause significant morbidity and mortality. They can cause hyperkalemia in therapeutic doses. Initial therapy focuses on basic management like administration of bolus of fluid and vasopressors for refractory cases. Captopril and other ACE inhibitors are thought to inhibit the metabolism of the enkephalins. Captopril and other ACE inhibitors inhibit the metabolism of the enkephalins. Naloxone, a mu-opioid antagonist, may reverse captopril-induced hypotension, but it is not universally effective. ARBs produce vasodilation and increase renal salt elimination. They are sartan like losartan, candesartan, irbesartan, valsartan, telmisartan. When they are taken therapeutically, the peak antihypotensive effect of agent is not observed for 4 weeks. They are not associated with significant morbidity. ACE inhibitors in ARBs can cause hyperkalemia due to decreased aldosterone production. This is more pronounced in renal insufficiency. So, in renal insufficiency patient, ACE inhibitor ARB can cause hyperkalemia. So, we don't give them in renal insufficiency. ACE inhibitors causes persistent dry cough due to bradykinin, substance P, and substance P. They are ARBs. Angioedema is caused by both ACE inhibitors and ARBs, but cough is caused by only ACE inhibitors. Cough will usually resolve in 1 to 4 weeks after the drug is stopped. ARBs are not associated with cough, but they can cause angioedema. It is an idiopathic reaction that occurs in about 0.1 to 0.7% of the patient describe the drug. Patient present with swelling of the lips, larynx, pharynx, tongues or vocal cord can range from mild to airway compromise. Symptoms develop over several hours and may not resolve for 24 hours or longer. How do you differentiate it from anaphylaxis? Though there will be no urticaria, abdominal swelling or genitourinary swelling. While in anaphylaxis there will be itching, urticaria, abdominal swelling and genitourinary swelling, but ACE inhibitors में ये सब नहीं होगा. So we differentiate ACE inhibitors induced angioedema from histamine mediated causes. The mechanism is due to ACE inhibitor mediated increase in bradykinin, substance P and other prostaglandins. The mean time from the first use to development of angioedema is about 2 years, but it can occur anytime during therapy. Management of ACE inhibitors induced edema is evaluation of airway. If the patient has difficulty breathing, stridor, lingual or oropharyngeal edema, then secure the airway by intubation. Fiber optic guided laryngoscopy is required and it requires minimal sedation and provides direct. Regardless of the method employed, a skilled operator should secure the airway early. Regardless of the method employed, a skilled operator should secure the airway early because angioedema can progress rapidly and anatomic layer, then you won't be able to intubate. Allergic reaction drugs such as epinephrine, antihistaminic and corticosteroids are often given but are not likely beneficial because ACE inhibitors is not mediated by histamine or immunoglobulins. Agents report beneficial are icatibant, a bradykinin 2 antagonist, C1 esterase inhibitor, human and fresh frozen plasma. क्या देना है? icatibant, C1 esterase inhibitor and FFP. After angioedema, discontinue your ACE inhibitors and ARBs. Next, we will study anticonvulsant poisoning. They are used to treat acute seizure and prevent convulsions in patients with epilepsy. The first generation of antiepileptics was consistent therapeutic levels have not been established for the second and third generation anticonvulsant, and serum levels are not a useful guide to therapy. The toxicity of two benzodiazepines used to treat seizures are clonazepam and clobazam is discussed somewhere else in benzodiazepine. बाकी क्या discuss हुआ है? Chapter reviews the. What are the classification of anticonvulsants? The first generation are carbmazepine, clonazepam, diazepam, lorazepam, phenobap, phenytoin, primidine, valproate. The second generation are your gabapentin, lamotrigine, levera, pregabalin, topiramate, phosphenitoin. And the third generation are your strepentol, brivaracetam and lacosamide. Coming to phenytoin and phosphenitoin. Phenytoin is a primary anticonvulsant for partial and GTCS. In conjunction with anticonvulsant, it is useful for non-drug-induced status epilepticus. It been used to prevent seizure due to head trauma. तो head trauma में phenytoin 100 mg BD देना ही है. In the immediate post-traumatic period and the management of some chronic pain syndrome also. Serious complications are rare if supportive care is provided. Most phenytoin-induced deaths have been associated with rapid IV administration or hypersensitivity reaction. Most of the deaths have been associated with rapid IV administration or hypersensitivity. It is oral and IV. Poor solubility of water in water, so vehicle use किया जाता है. That is, vehicle is used for parenteral formulation. That is 40% propylene glycol and 10% ethanol. adjusted for a pH of 12 with phenytoin infusion is usually ascribed to the with a pH of 12. तो 40% propylene glycol and 10% ethanol is used. Adjusted to a pH of 12 is highly alkaline with NOH. So sodium hydroxide is added to make it water soluble with propylene glycol, 40% propylene glycol and 10% ethanol and NOH. The acute cardiovascular toxicity seen with IV phenytoin is usually ascribed to the propylene glycol diluent. So propylene glycol is cardiotoxic. Other limitations of parenteral phenytoin are irritating and the tendency to precipitate in IV solution. Phosphenytoin. It is a disodium phosphate ester of phenytoin is a prodrug that is converted to phenytoin by phosphatases in the body with a conversion half-life of 10 to 15 minutes. The advantage of parenteral phosphenytoin is that it is soluble in water. It is a buffered to a pH of 8.8. It's non-irritating and can be given via IM injection. So we don't need a preservative like propylene glycol. We do buffered pH is 8.8 only, very similar to compared to the phenytoin, similar to physiological pH. It's non-irritating to the tissue and can be given via IM injection. So if you want to give soda bicarb in a patient of seizure and they are having acidosis, you can use phenytoin. Mechanism of action, it is blocking sodium voltage gated channel. Voltage sensitive and frequency dependent sodium channels are blocked, suppressing the neuronal activity, preventing the spread of seizure focus. Pharmacokinetics, phenytoin is a weak acid. Most of the drug is ionized and aqueous solubility is limited. Different phenytoin preparations can have major differences in bioavailability. It may be necessary to obtain serial measurement of serum levels in suspected overdose to determine peak levels. They typically occur between 3 to 12 hours after a oral ingestion. Phenytoin is extensively about 90% bound to plasma protein, especially albumin. It is unbound fraction is higher in hypoalbuminemia, renal failure. Drugs that displace phenytoin from its albumin binding site are aspirin, valproate, phenylbutazone, tolbutamide and sulfate. They also result in increase in unbound fraction. 95% of phenytoin is metabolized by liver. It is dose dependent, capacity limited, dose dependent. At plasma concentration less than 10 microgram per ml, it is eliminated by first order. At higher concentration, including in the therapeutic range, which is your 10 to 20 microgram per ml. Therapeutic range, what is the therapeutic range of phenytoin? 10 to 20 microgram per ml. It is zero order kinetics. So remember, phenytoin 0 watt power is zero order kinetics. These are the drugs with zero order kinetics: warfarin, alcohol, aspirin, theophylline, tolbutamide and phenytoin. Warfarin, alcohol, aspirin, theophylline, tolbutamide and phenytoin. This is the half-life of the first generation anticonvulsant drugs: oral dose, maximum oral daily dose and the half-life. Phenytoin is zero order kinetics. 10 to 20 microgram per ml is the therapeutic range. Incremental dose increase should be limited to 30 to 50 microgram at a time and levels should be carefully monitored when it is necessary to raise phenytoin dose above 300. Propylene glycol and ethanol diuresis. Propylene glycol is a potent myocardial suppressant. 40% propylene glycol and 10% ethanol with NaOH यूज़ करते थे ना. तो propylene glycol is a potent myocardial depressant and vasodilator. It increases vagal tone. It can cause coma, seizure, circulatory collapse, ventricular arrhythmia, AV block and hypotension, hyperosmolality, hemolysis, lactic acidosis. And ethanol can produce disulfiram reaction. Clinical features are cerebellar and vestibular signs. Clinical features of phenytoin toxicity are given here. CNS में dizziness, tremor, visual disturbance. Peripheral में peripheral neuropathy, hypersensitivity, GI. Phenytoin is a potent hepatic enzyme inducer, CYP450 inducer. That is why ये आता है ना कि एक पेशेंट थी सीजर की, फेनेटॉइन ले रही थी तो वो प्रेग्नेंट हो गई. क्यों? क्योंकि उसकी OCP फेल कर दी फेनेटॉइन ने CYP450 को इंड्यूस करके, है ना. तो CYP450 इंड्यूसर है, इंक्लूडिंग CYP3A4, CYP2C9, 2C19 सबको इंड्यूस करता है. सो बाकी सारी ड्रग्स का मेटाबॉलिज्म और ब्रेकडाउन बढ़ा देगा, उनका इफेक्ट कम कर देगा. बाकी साइड इफ़ेक्ट्स क्या है फेनेटॉइन के? P450 इंड्यूसर, पर्पल ग्लव, H से हेयर ग्रोथ, हिर्सुटिज्म होगा, E से एनलार्ज गम्स, निस्टैग्मस, यकी स्किन रैशेस, टेराटोजेनिक ऑस्टियोपोरोसिस, इंटरफेयर्स विथ फोलिक एसिड अनीमिया एंड न्यूरोपैथीज. So peripheral neuropathy, hypersensitivity, enlarged gland, nystagmus, teratogenic osteoporosis, neutropenia, anemia and neuropathies. And phenytoin causes many drug interactions. Phenytoin increases serum levels of PCM, acetazolamide, amiodarone, OCPs. ये पढ़ लेना थोड़ा थोड़ा. What is the cardiovascular toxicity of phenytoin? Cardiovascular complications have been almost entirely limited to class of cases of IV administration. Means only the additive propylene glycol is toxic, in large part due to the constitute of the parenteral vehicle, in rare case with chronic oral toxicity. Patients with a history of previous hypersensitivity reaction should not be given phenytoin, and because of the similar reaction to phenobarb, lamotrigine, felbamate and carbmazepine, these are also to be avoided in phenytoin reaction. The therapeutic phenytoin serum level is 10 to 20 microgram per ml. Although 50%, the ratio of toxic dose is rather low and the narrow therapeutic index. Toxicity is not an absolute level, but it is correlated with increasing plasma levels. So correlation of toxicity with plasma level, तो less than 10 it's none, 10 to 20 is nystagmus, then first nystagmus आएगा, उसके बाद ataxia, slurred speech, nausea and vomiting, last में there will be lethargy, confusion and coma, seizure. Treatment, the initial treatment is similar to that of any other injection, correct the acidosis, decrease active free fat phenytoin, multi-dose activated charcoal. Seizures are treated with benzos or phenobarb, with the caution that seizures are uncommon in phenytoin overdose. So, search for other causes. For patients with severe and persistent toxicity, hemodialysis and hemoperfusion can produce substantial improvement in neurological toxicity. Cardiac monitoring is unnecessary Atropine and TPI may be used for symptomatic brady. Hypotension that occurs during IV administration of phenytoin or phosphenytoin usually responds to discontinuation of the infusion and administration of fluid. Hypotension is responsive to fluid only. Disposition and follow up कैसे करेंगे? Phenytoin has a long and erratic absorption phase after oral overdose. So the discharge cannot be based on the serum level. At least 2 to 3 days is required for observation. Next is carbmazepine. Carbmazepine is a primary anticonvulsant used in a treatment of partial and tonic-clonic seizure. Other uses include trigeminal neuralgia, chronic pain disorder, mania and bipolar disorder. It inhibits sodium channel, interferes with muscarinic acetylcholine receptor, nicotinic acetylcholine receptor, NMDA receptors and CNS adenosine receptors. तो कितने कमाल के रिसेप्टर्स हो गए? मस्कैरिनिक, निकोटिनिक, NMDA विच इज़ योर केटामिन वाला, NMDA एंटागोनिस्ट था केटामिन, एंड अडीनोसिन को ब्लॉक करता था कौन? कैफीन. सो कार्माजेपिन इनहिबिट्स योर सोडियम चैनल एंड इंटरफेयर्स. अच्छा, इंटरफेयर्स है इसमें, इनहिबिट है कि स्टिमुलेट है या पता नहीं है. कार्माजेपिन हैज सेंट्रल एंटी डायूरेटिक इफेक्ट विच में लीड टू SIADH. सो कार्माजेपिन में लीड टू SIADH. It is a potent CYP450 inducer like phenytoin. Phenytoin की पार्टी का है ये. CYP450 induces and enhances its own metabolism over time. Carbamazepine is structurally similar to imipramine. Therapeutic levels are 8 to 12. 80% protein bound, metabolized by CYP450. Responsible for much of the neurotoxicity, and it is converted to active form by CYP450, and carbamazepine is a CYP450 inducers, so it is promoting its own induction. Auto induction of the enzyme occurs after about 1 month of continuous use, decreasing the half-life, elimination half-life. Acute toxicity include mental status, depression, ataxia, nystagmus, ileus, hypertonicity and increased DTR, dystonic reactions and anticholinergic toxidrome. Paradoxical seizure can occur in high concentration. LV dysfunction, heart failure, transient heart block can occur. Cardiac arrhythmias are rarely seen, but carbamazepine is one of the few drugs that can potentially cause both a wide QRS and seizures. Labs are hyponatremia, hyperglycemia and transient elevation of liver enzyme levels. Diagnosis is by serum levels. They do not correlate with the poisoning severity, but more than 40 are increased risk of serious complication like seizure, respiratory failure, coma, cardiac conduction delays. Serum concentration higher than 60 to 80 may be fatal. So clinical judgment is more important. Because the chemical structure of carbamazepine is related to imipramine, carbamazepine can cause a false positive tricyclic antidepressant result on urine drug screen. How do you treat it? Activated charcoal should be used if patient present within 1 hour. Multi-dose activated charcoal may be used. In patient with severe toxicity and multi-organ dysfunction, hemodialysis, hemoperfusion and hemodiafiltrations are effective. So in patients with severe toxicity and multi-organ dysfunction, hemodialysis, hemoperfusion and hemodiafiltration are effective. If cardiac conduction delays is noted on the ECG, Sodium bicarbonate treatment is given because it is a sodium channel blocker. Carbmazepine and phenytoin are sodium channel blocker. Similarly, TCA also blocks sodium channel. Class 1 antiarrhythmic also blocks sodium channel. Patient can be disposed of if serial carbamazepine obtained over a few hours apart are less than 15, both less than 15, and they are not increasing their falling levels. Next is valproic acid.